Hi, my name is Mary Jane Woods, and I'm here to present a case presentation. I am a nurse practitioner student, and I'm here to present a case. This is about a 68-year-old male who presented to our emergency room with the symptoms of chest pain. EKG was done upon arrival to the emergency room, and it shows anterior MI, which is lead um, V3, 4, and has so heart alert was called and patient was brought to cath lab for a heart alert. Cardiologists found that patient has a multivessel disease. Left main is about 70 to 80%. LAD is about 70 to 80% included. Ramus is about 70 to 80% included. Left circumflex and the right coronary arteries is about 70 to 80%. So patient has a multivessel disease. With that disease process, cardiologists consulted the CT surgeon for evaluation and for urgent or emergency open heart. While waiting for the cardiothoracic surgeons to come in and evaluate the patient, cardiologists placed an intra-aortic balloon pump to a patient in the cath lab. Upon arrival of the CT surgeon, and it was discussed with the cardiologist the need of open heart. Patient was brought, the heart team was called in, and patient was brought to the CVOR for an emergency open heart. Patient had 4 vessel bypass. That include using the Lima to bypass the left anterior descending, using his saphenous vein, left saphenous vein from his legs to bypass the diagonal, the OM, obtuse marginalis, and the circumflex. Patient was done on pump and bled about patients receive about like 4 units of red blood cells and 2 packs of FFP, of fresh frozen plasma. Upon surgery or upon ending of the surgery, patients went straight to the intensive care unit with the balloon pump. Patients presented to the ICU, intubated, sedated with intra-aortic balloon pump, and hemodynamically unstable with cardiac monitors, hemodynamic monitors, and 2 chest tubes. Patient was getting or receiving 4 different cryopressors, vasopressors to maintain his hemodynamics. He's on milrinone, which is 0.25 mics per kilogram per minute for to improve his cardiac output. Nitro is also infusing to maintain his systolic pressures about less than 140 milli per mercury. And at times, or it's off right now, or it's off upon arrival to ICU, Levophed, which is to maintain his systolic pressures greater than 90, and a good augmentation is about 70 milli per mercury. Family history, patients, we did not able to get a lot about the family history of the patients because patients presented with a severe chest pain and not able to obtain that, and he doesn't have any friends at that time. But medical history from his friends from San Antonio said that the last time he went to see a doctor was 20 years ago. And with his past social history, a patient is a country songwriter, and he's write songs to some of the famous country musicians and won some award per patient. Patient is not per patient, per patient's family friends, excuse me. He is not married, no children, and both parents are deceased and doesn't have any siblings. Patient does smokes about 1 to 1.5 a pack of cigarette, and he drinks unknown how much amount of alcohol. Patient doesn't have any allergy, no drug allergy. For his current medications, patient has milrinone, which is all IVs. Milrinone is about 0.25 mics per kg per minute. This is for to improve his cardiac output, and an inotrope. Levophed is a standby. This is to maintain his pressure at least above 90 milli per mercury. And nitro, which is running at about 10 mics per minute, between 10 to 20 mics This is to maintain his systolic pressure is about 140. Patients is insulin drip to maintain his sugar less than 140. For subjectives, patients is intubated and sedated and critically uh, conditioned in ICU. It's in a balloon pump. It's 1-to-1, and with a good augmentation is about 90, greater than 90. It's about 90 to 100. He's on pressors, like I said, Levophed and milrinone. And we can't really obtain much about subjectives, but with his objectives, his vital signs are stable. His BP, blood pressure is about 110/65. His pulse rate is about 80 and 90, and no ectopy. Patient is in a balloon pump. It's a 1-to-1 with a good augmentations, which is greater than 100. And patient is intubated. He's on setting. It's a AC of 12. He's in assist control of 12. Tidal volume about 550. And he's a PEEP of 7. And he's an FiO2 of 60%. His general appearance is he's pale, he's sedated, and with propofol, and he's a little bit cold, clammy. With his head, ear, eyes, nose, and throat, head is normocephalic with no masses or lesion. His pupils is the conjunctiva is clear, but you see an edema in it or swollen. Sclera is white. He has JVD is it's normal JVD, and with his neck's absence of tenderness, but you can see he has a right IJ Swan-Ganz. With his lymphatic, he has a no enlarged lymph nodes. With his cardiac, he's in sinus rhythm, no ectopy. He's in a balloon pump. It's access in the right groin. It's 1-to-1 with a good augmentation. His hemodynamics are stable. His cardiac output is about 3.6 to 4, with his index is about 2.2 to 2.6. His abdomen is soft, tender, without masses. Bowel sounds is hypoactive, but there's no sign of hepatomegaly or enlargement of the or enlargement of spleen or any organs. Extremities, not able to assess at this time with his extremities, but he's about +1 and +2 edema. Pulses are present per Doppler on the right leg. Musculoskeletal, patients in bed rest and sedated, but there's no swelling of the joint. Laboratory. His CBC, his white cells is about 10.2. His HNase is 9.8 and 30.1. And his platelet is 351, which is good. His chemistry, though, he's a little bit hyponatremia. It's 127, and his potassium is like 3.4, and his mag is 2.4. His chloride is 97. His CO2 is 31. His BU and creatinine is like 169 and 1.7, and his glucose is about 161. And he's an insulin drip per protocol. For diagnostic, we did a chest x-ray upon arrival to check the placement of the aortic balloon pump, the ET tube, the swan, and also to see, to assess any possible cardiac tamponade or any pleural effusions, which shows patient has a little enlargement of the heart and also shows a right pleural effusion. And the balloon pump placement is in the right place. Echocardiogram was also done. This is to evaluate the ejection fractions or the cardiac functions. And with the balloon pump, patient has a 1-to-1 ejection fraction is 1-to-1 augmentation, 1-to-1 balloon pump with ejection fraction of 30%. This is with the balloon pump. So without the balloon pump, it's about 10%. For assessment and plan, so we know with assessment that patients is hemodynamically unstable after an emergent open heart and needing to stay in the balloon pump for at least 1 or 2 days and maintain and make to watch or to monitor the bleeding and the hemodynamics. And also for the plan too is to diaries the patients before we can wean the balloon pump. Lasix is started to at least 20 milligram of Lasix until because it shows in the X-ray, and also the patient has a CHF and also right pleural effusion. Lasix is ordered about 20 milligram IV every 8 hours to diuresis the patients in order to able to wean the balloon pump and also extubate the patient. The plan is to diuresis the patients, wean the balloon pump, and then wean the mechanical ventilations if possible, as soon as possible, with hemodynamically stable. With that said, patients, upon doing the assessment, patient is still in an ICU. Balloon pump is 1-to-2 augmentations, and milrinone is still running at 0.25 mics per kg, but Levophed is off and nitro is off. And the cardiac output at this time upon assessment is about 4.0 and index about 2.6. And that's it. Thank you.